Next up, we want to make a very warm welcome to Marije Weidema from the Radboud University Medical Center in the Netherlands. Thank you for taking your evening hours to be with us today. We are excited to hear about differences in quality of life between EHE patients, a global and online patient-initiated study. Please welcome Ms. Weidema.
Yes, thank you very much. Good afternoon, good evening for everyone who's watching, and thank you very much for the invitation to tell you something about our study. My name is Marije Weidema, and I'm a PhD student from the Netherlands, also a medical doctor in training. And I'm going to tell you something about our quality of life study, which was initiated by EHE Patient Foundations and was a global and online study. Short overview of my presentation. I'll start with just a little bit of background and then share kind of the story of the study initiation. Then I'll share the methods we used, the results we gained, of course, and the conclusions we can draw from these results. And of course, in the end, there'll be time for questions. Usually in other presentations or in other conferences, I have to, do a large introduction on EHE, but in this case, I don't think it's necessary. But I think some important aspects of the disease that are also relevant for the quality of life, interest in quality of life, it's the fact that it's a really rare cancer and already mentioned a very large variation in the clinical course. Also the fact that it's a really unpredictable disease and that pain is also commonly reported. And it's important to realize that before this study, there was not yet any data on, for instance, symptom intensity and no data on the health-related quality of life of EHE patients. So, let's see, next slide. Yes, so on the CETUS conference in 2016, which is a conference of the Connective Tissue Oncology Society, in Lisbon in 2016, there was a presentation by Professor Lonneke van der Pol from the Netherlands on her system to collect data of patient-reported outcomes online in a safe environment. And afterwards, Hugh Leonard from the EHE Foundation from the United Kingdom met with Professor van der Pol, and he said, I have a large online group of EHE patients, and wouldn't it be interesting to study quality of life of these patients using your profiles management system? And so a study was born and a research team was assembled, including clinical experts, and Lonneke, she searched for a PhD student to kind of adopt this project, and that was me, luckily enough. Next slide, let's see. So, like I mentioned, until now, there has been no scientific studies about health-related quality of life in EHE. And I think it's interesting to investigate because, first, it's a very unpredictable disease with, which is not easy, not hard to imagine that might lead to, for instance, anxiety or worries about the future. The fact that it's extremely rare makes it very difficult or more challenging to find expert doctors. And you have to deal with the fact that there's limited knowledge on EHE, period, even worldwide. And of course, the symptoms can be heavy, can be intense. They can have a large impact on patients' lives, and they can also last for quite a long time because it can be such an indolent disease as well. And I think we just already heard some impressive stories from EHE patients, but these are two quotes that we gathered in the study. And the first person said that since my diagnosis and because the scans have indicated no or very slow growth, I'm not receiving as much attention at my appointments. I'm still trying very hard to understand this cancer, and I don't feel like I'm getting a lot of information. I think that's a pretty serious experience with a lot of, grief and suffering behind it. And the second person said, as an ex-breast cancer patient, I am amazed at the lack of support provided to people with rare conditions compared to the support that I was offered 10 years ago. So I think that both these quotes highlight the need for, well, more attention for quality of life of EHE patients in the research community. So what we did with the study is we designed a questionnaire using the EORTC QLQC30, which is a very common questionnaire in quality of life study with cancer patients. And it addresses both symptoms as well as daily functioning, and it encompasses questions such as, do you have any trouble taking a long walk? And all questions are regarding the last week. But apart from this questionnaire, we also requested input from EHE patients or EHE patient experts because we wanted to make sure that we addressed also symptoms relevant for EHE specifically. So we added, based on this input, some extra questions on, for instance, particular symptoms. And next to the quality of life part, we also included a questionnaire regarding anxiety and depression. It's the hospital anxiety and depression scale. So our research goals were to, well, first explore quality of life of EHE patients and also investigate the relationship between symptoms and quality of life to see if there is one, and if we could identify maybe patient groups based on the presence of symptoms. So we included patients mostly through posts in the EHE Facebook group, and all the members of the EHE Foundations from the UK, US, and Australia received several emails with the invitation to participate. So all patients filled in the questionnaire online using the profile system, and all patients were enrolled in 2018 between May and October, so quite a short period of time actually. So starting with the results, we had an astonishing number of participants, 115 from 20 different countries, mostly from the USA, but also from China, Brazil, the Netherlands, all over the world. Mean age of the participants was 47 years. Like we saw in the presentation of Lisa, about 3/4 of them were female. And 80% was not currently undergoing any treatments for the EHE. And the mean time since diagnosis was 4.5 years. So we first looked at the symptoms, and we intended to, well, identify subgroups of patients based on the presence or absence of 10 different, we thought, relevant symptoms, including fatigue, nausea, appetite, insomnia, the presence of pain, constipation, diarrhea, skin problems, respiratory problems, and stomach problems. And we performed a latent cluster analysis, which is kind of a way to see if, particular patients kind of cluster together because they have the same characteristics. And this led to 3 different clusters. The first was the cluster with low symptom burden, with 27% of patients in it. 40% of patients were regarded to have an intermediate symptom burden, so some symptoms but not too many. And 33% fell in the high symptom burden, so they had relatively many symptoms. So we were interested to see which patients are in the high symptom burden cluster, and these were all patients, or these patients more often had aggressive disease compared to the other 2 clusters. They also more often had bone or pleural lesions and a little less time since diagnosis, but still quite long. I think the mean was about 3.5 years still. So then we looked to not just the presence of symptoms, but really the symptom intensity, so the symptom scores. And as you can see in this graph, patients with a low symptom burden have the light-colored bars. They all, I think the bars aren't almost not visible, so they had very low scores. But you can see strikingly high scores for the patients with the high symptom burden, also with statistically relevant differences. And so these are just numbers, but we compared the scores from the patient with the high symptom burden to scores from another study with the cancer patients in their last 3 months of their life, so really in the terminal phase. And their scores were equal or sometimes even lower than those of the EHE patients. So I thought that was pretty shocking. It gives a good idea of the burden of the symptom intensity. And next, we looked at functioning. So in this case, a higher score means better functioning. So you see that the patients with the low symptom burden have almost 90 to 100 points on functioning. So they have good or little impact of EHE on their daily life. According to these scales at least. And then again, you see a large difference between those patients with high symptom burden with lower functioning on practically every scale that we investigated. So physically, role functioning, which means if you can still be a good teacher or a good father, like cognitive functioning, emotionally, but also socially, and the global quality of life. And then to get even more sense of how well or how badly patients function, we compared them to healthy Europeans, which are people not having cancer, and we compared them only to patients from the same age or the same sex. So when we compared the entire group of EHE patients, we found no difference in functioning compared to these healthy Europeans. So the scores were more or less the same. But then we looked specifically to the symptom cluster. So the patients with low symptom burden actually had better functioning than those healthy controls. Patients with intermediate symptom burden, their functioning was better or similar to those healthy controls. But patients with the high symptom burden, their functioning was significantly worse than the healthy controls, which is depicted in the graph. You can see the patients in the white bars with much lower scores than the norm, so the healthy Europeans. And then we investigated depression and anxiety, and we looked at the percentage of patients that was above the thresholds. There was a threshold of, I think, about 7 points. Below that, you were considered not depressed, and above, considered depressed. Same for anxiety. And you can see the large difference again in the darker bars with the high symptom burden group, that almost 40% of patients were considered depressed, and even more than 40%, I think around 50%, considered as very anxious. So I think these are also pretty impressive numbers. So what did we learn? Well, we were able to start a study initiated by patient or a patient foundation, and able to use a very quite innovative study design. I mean, I've never used Facebook before to perform a clinical trial, but it did enable us to include 150 participants in such a rare cancer. So we learned that it's very important to recognize the highly symptomatic patients, because if you look at the entire group of EHE patients and you look at the scores, you might think, well, that's not so bad. But if you zoom in, you see that there's quite a lot of symptom burden in these highly symptomatic patients, and these patients more often have bone or pleural lesions, which is important for clinicians to help recognize these patients. And it also emphasizes the need, I think, that we need to improve pain management, learn more about EHE-related pain, and how to support patients better. And like I said, we saw some really large differences between EHE patients, both regarding symptoms, but also regarding quality of life, and also regarding the psychological impact of the disease. So it's already a very, very rare disease, but it's still relevant to maybe identify or zoom into subgroups to be able to provide better care and learn even more about this disease. So I wanted to share one more story which really touched me when I read it. This was a patient who participated in the study and said, well, my physical condition is not my impediment to my daily life. It's the mental weight of having EHE that impacts all kinds of decisions an EHE patient takes in life, financially, family. It feels like having AIDS, incurable but able to function in life, usually with the dread of death in each decision. So I think these are, well, beautiful but also painful words, and maybe even these stories cannot be caught in, questionnaires. So it's also important to share the stories, I think, behind the numbers. And it's important to realize that you can never perform research on your own. So I'm really, really thankful to the EHE Foundations, and of course, mostly to the patients and the caregivers who dedicated their time and effort to participate in the study. And I'd like to thank you, Leonard, and Lisa Hartel de Jong for their collaboration on this beautiful project. Then Professor Lanneke van der Pol and Dr. Olga Husson from the Netherlands Cancer Institute, who have so much experience with quality of life studies. Then my supervisors from the Medical Oncology Department, Dr. Ingrid de Zaar and Professor Rinette van der Graaf, who are sarcoma experts, not only clinicians, but also in research. And Dr. Belle de Rooij, who helped me with the cluster analysis to identify the subgroups. So thank you very much for your attention, and I wonder if there are any questions.
Yes, so definitely questions. First of all, thank you for doing this work. With a rare cancer, usually doesn't get this type of attention, and as your data showed, there's some very interesting takeaways from the data. So thank you for doing the work. The first question, do you have any plans for a follow-up study?
Well, that's a good question. I think we also included some questionnaires on supportive care. So how patients experience their care, and if they, I think that's the best summary. So yes, we are planning to, publish more results of this study. And I think it would be wonderful to, plan an even bigger study or a sequel, but that has not been planned yet, as far as I know.
And did you collect demographic information about the survey participants so that you could answer questions about whether you're seeing things like geographic differences or other types of demographic differences of patients ending up in the different categories, socioeconomic, racial, region of origin, any of those factors?
I think we have some information, but for instance, we only collected data on, what country are you from? And I think, for instance, United States of America is, for example, a very large country, or China. I think it's, I'm not sure. I think socioeconomic status. Well, we tried to ask people about their level of education, but because it's such a global study, it was kind of difficult to, maybe compare the different systems. In conclusion, we did collect some data, but probably not as specific as we might have wanted to, in hindsight, to be able to say a bit more about those factors.
And then in your data collection, did you ask about or collect information about therapies or interventions that the patients were undergoing to try to differentiate symptoms caused by disease versus symptoms caused by treatment, or maybe it didn't matter one way or the other in terms of the experience, but could you speak to that a little bit?
Yes, we did collect those data. I think only 20% of patients were currently undergoing treatment, and we did compare the different kind of treatments with between the symptom clusters. There were no significant differences, but it's already quite a small group of people. And I think it's important to consider that the questionnaire we used only reports on symptoms on the past week. So if you're having chemotherapy, for instance, week 1 or week 3 can already be, show large differences. So yes, we do have some of the data, but I'm not sure if we are able to provide really reliable interpretations.
And then you noted in the high symptom group, a high rate of depression. Do you have a sense of how that those numbers compare to other cancer types? Is EHE falling into a traditional pattern there, or is that a higher number?
Oh, that's a good question. I'm not sure if I have the exact numbers, but I think if you look at the highly symptomatic group, the numbers are slightly higher, I'd say, than in other cancers. I think maybe one important factor is the fact that it has such a long long disease trajectory. So also, people do not only suffer intensely, but also for a long period of time, and probably deal with more insecurities, even more insecurities than other cancer patients regarding their future.
Yeah. That's all of our time for the Q&A. I do want to make a comment, though. Having you speak at this conference, I think, is very important. Getting this information in front of patient groups and clinicians is very important. Your data revealed things like high levels of insomnia, appetite issues, financial issues. These are all things that, to various extents, clinical treatment are not going to fully address, but might be very important to address for patient health. And then it looked like one of the downstream effects of this was a decrease in social functioning. Again, something that might be really critical for patient health that the broader community needs to help address, where physicians may not be in a position to do so. So thank you very much.
Yes. Thank you.
Turning it back to Jenny.
Great. Well, thank you, Ms. Weidema. Thank you so much for being here. This is really interesting data, and all of us patients are very appreciative of being able to be part of it. Not only do EHE patients sometimes deal with physical pain, but also a tremendous amount of emotional distress. I always relate EHE to living with a time bomb inside me and never knowing when it's going to go off. So this can be really hard. And I just want to thank you for looking at our patient quality of life holistically. Also, a little birdie told me that you have halted your research work to help fight COVID in your local hospital. So thank you very much for your dedication, not only to EHE, but to fighting COVID. Appreciate you.